Welcome back to Building Better Businesses in ABA with me, Jonathan Mueller. It's a weekly podcast about the forces reshaping our autism services field. Learn from successful entrepreneurs, payers, investors, and leaders in applied behavior analysis. Thank you, kind listener, for letting me into your world today. Now on to the show. My guest today is Dr. Diana Davis Wilson. Diana is a licensed behavior analyst and chief executive advisor of Aspen Behavioral Consulting. She's a governor-appointed member serving on the Arizona Board of Psychologist Examiners, and she's a university professor. Her past roles include leadership positions at Arizona-based autism provider organizations, overseeing ABA programs for hundreds of children statewide. Diana, welcome to the pod.
Thank you. Thank you so much for having me. I'm excited. I'm excited to speak with you today.
I'm excited to catch up with you. Oh my gosh, we're going to have a far-ranging discussion. I have to tell you, Diana, and I don't think I've ever told you this before, but like one of the things that so endeared me to you, it must have been 4.5 or 5 years ago, was a Gentry Foundation event. It was a fundraising event. This was way pre-COVID. I don't know, 2018-ish maybe. And I came down and I kid you not, I was trying to get gussied up and dressed up all fancily. And I spent an hour in my hotel room trying to trying to learn how to tie a bow tie. I had like 3 different YouTubes going. I was looking in the mirror. After an hour, I was so frustrated with myself. Like I almost turned around and it just didn't go altogether. So I was like super frazzled showing up. I didn't know anyone there. These are the earliest days of Ascent. And who was there but you and your husband, some other friends. You were so welcoming and kind. And it was such a fun night and an awesome cause. So can I just tell you publicly, like, thank you so much for being so welcoming.
Oh, thank you. You looked really well put together.
Oh,
I wouldn't have even guessed it. That was a great night. I think that it's a great foundation and a great cause, and every year they do it, and it's just a really neat opportunity to kind of connect and get to know everybody. It's hard for me because I also don't dress up. And I do believe that night my business partner convinced me to, and we actually got all semi fancy. I remember it vaguely, mostly because I remember trying to wear heels, and I had to actually take the shoes off to walk from the parking lot to the event, and then about halfway through the event, I just took my shoes off entirely too. But if anybody knows me, you know I wear jeans and flip-flops and sunglasses. I don't even know what I did with my sunglasses right before this call. I almost went to go get them, and then I was like, "No, I can do it without. I can do it without." So, that was a great event, and I am so glad that we've been able to connect and get to know each other and, work on some projects together, and I know you guys do some incredible work, and it's been a joy.
right on. Thank you, friend. That means a ton to me. Well, this is a story that you described to me very recently, but I mean, you have seen and you understand value-based care at its best. And that goes all the way back to your doctorate program. Can you tell me a little bit more about your doctorate program and your experience working with a primary care doc in rural Douglas, Arizona?
Yeah, absolutely. So I went a little bit of a different route with my doctorate. I know a lot of people ask like, why didn't you go and do behavior analysis? Well, because I had my master's in that and I was doing that and I had been practicing for a year. And the area that I just kept running up against was kind of the public policy and some of those other initiatives. And when I started in the field, we didn't have health insurance covering services. You were contracting with the schools or you had some families that had the ability to pay for services. But for the most part, there wasn't a lot of funding streams. And right around the same time that all of that got going, I had my firstborn and he was diagnosed with autism by 15 months old. So I had to quickly shift into a parent role. And that was tough because as providers, I mean, we have our ways and then all of a sudden I'm mom and I needed to navigate the system. And I had been working in Arizona in the system for 8 years before I had my son. And so we're, approaching 10 years by the time I now need to navigate services for him. And I couldn't do it. And it took a lot of work and a lot of loopholes and calling people that I had built relationships with over the years. And then I just felt kind of gross, like that here I am, I can make this phone call and get my child whatever they need. And there are hundreds of families that just can't access services. So I was looking to do my doctorate in an area that would focus on accessibility of care and serving marginalized communities and looking at ways that we can better take what we know to be just an incredible science and apply it outside of that typical you get a referral from the insurance company and you provide early intervention services or what have you, and kind of expand beyond that a bit. So I decided I was gonna find a degree, and it was recommended that I do the doctorate of behavioral health, and the reason is because it was, like, part clinical at the time. It's changed a lot, so, I'm gonna date myself. This was before there was a clinical and management track. So there was the clinical piece, and then there was the management, leadership, entrepreneurial piece, and then there was the funder relations piece, and that funders relations piece was the part that I just knew that was kind of the ticket into figuring out ways to expand behavior analysis outside of the realm of restricted autism service coverage that we had. So as part of my doctorate, I had to do a practicum, and I was very fortunate. Dr. Robin Blitz at Phoenix Children's Hospital had right around the same time started talking about her initiatives of wanting to help some of the primary care practices, the pediatric practices, meet their metrics for value based care. And one of the ways that she had proposed doing that, because in primary care, your two largest metrics, three, you have the attendance of your well child visits and your preventative care. Then you have tied to that your reduction of hospitalizations, urgent care, and ER visits. And then you have, in most of the metrics, a reduction in specialty provider referrals, which I don't know that that's talked about as much, but that was the piece that we were honing in on. Because what we had found was this very strange phenomenon of pediatricians that would see a child with autism or genetic abnormality or something, and they would all of a sudden not know how to treat constipation, or all of a sudden not know, like, basic child ailments. Oh, the child has frequent ear infections, but they also have autism, therefore they must go here or they must see this. And we went out, we had interviewed the specialty providers, and they were just like, if a pediatrician sends us one more child with autism with basic constipation and they've done nothing else to fix it, we're going to lose our minds because they've got kids that need feeding tubes and kids that have Crohn's and all these other things, and they're seeing primary care visit like services. And so Dr. Blitz had envisioned this training program where we could actually go out into the community and provide training to the pediatricians on how to do their jobs within the confounds of the special healthcare needs is kind of how we worded it. It wasn't limited to just autism, but it was special healthcare needs. So it was kind of like her brainchild, and it was kind of a spin-off of some work that was done in Ohio. And then I'm sure you're aware of the Echo Autism. We were very closely connected with the work that they were doing. And she had secured a grant for us to do rural communities in Arizona. And so we had about 40 practices, which was great. And we got lucky in that most of the practices had some sort of personal connection with autism. So we didn't have to, like, they were personally invested, which helped because sometimes you get a lot of people that kind of drop off after a while because of the time commitments and stuff. They're personally invested in it. And then we had several individuals that were former students of Dr. Blitz that then went into primary care practice that just wanted to tie in what they had learned into their practice. And at the time, so, we're talking 2014, that was when the big talks of value based contracting were going on. And that was when, because it was following a rendition of the Affordable Care Act that also incentivized federal dollars to go to these value based programs. So I was very fortunate that one of the practices that I was assigned to go out and assist with was in Douglas, Arizona, which is one of our border towns. And this pediatrician had received several value based contracts and grants and programs to essentially set up health clinics that would meet larger community initiatives. So, not initiatives that were just specific to reduction of ER visits, but bigger than that. She did have the metric for the well child and preventative visits. But one of her other big projects was to actually reduce the occurrence of teenage pregnancy and the subsequent health concerns that come with babies having babies. And so when you think about that and you're like, okay, how does one doctor in our current healthcare system come up with some way to reduce teenage pregnancy? Seems kind of crazy, right? But she had figured out a really cool program and she had used her money to forthright set up her doctor's office to include a library. It includes kind of a study hall. It included a coffee shop, like all of the things that teenagers would want to come in and have for free. She built that within her practice. And then what she started to do, and again, it's a border town, and so you've got multi-generation pregnancies happening even within homes. She had set up cohorts for the OB visits because what she realized is that part of why the healthcare, what she hypothesized was part of why the healthcare metrics for the teenage moms, the pediatrics, so the babies getting access to adequate healthcare was because the teenage moms didn't have transportation. They had, different support systems. They were also going to school. And so she had came up with a model where they had monthly cohorts and anybody who was due within that month, obviously with HIPAA and consent and all of that, signed into being in this cohort. So not only were you seeing this doctor who was a pediatrician by trade, but she had a whole health center. So she was able to have all other types of providers as well. But her entire goal was to make it so that you weren't going through pregnancy alone, regardless of your age, regardless of your circumstances. And through that, to build systems to where you had the community support to get you into the facilities and those sorts of things. And then what she did was she set up patient education systems. So now it's, hey, whoever's bringing you in, we're now going to do an education program to reduce the reoccurrence of the teenage pregnancy with the end goal of getting out and having programs for just high schoolers in general to be able to come in, perhaps get some high school credit and go through some patient education to prevent some of that. What's really neat about that and where value-based comes in is, as we know, it's always the chicken or the egg. You need the money to purchase the facilities to, house the kids, and which one comes first and how do you balance that? And rather than like the investor model, she went the federal qualified health center model where she basically would send her metrics into the federal government, and depending on what her outcomes were was how much money they would then continue to pay her. And so her entire model was based on, she did have some grant funding going because there was some logistics around immigration status and some things like that that she needed. And then they also actually traveled, I can't remember where, but her husband was also a physician and they also traveled to underserved communities in other countries and did community service. So she did also have some grant money, but for the most part, it was under this value-based system where you no longer had to worry about how much time you were spending with each patient just to be able to pay all of your other metrics. Instead, she could actually see the patients in a cohort and she didn't have to worry about concurrent billing or duplications in billing or any of that because she wasn't billing by the hour. She was billing by the outcome. And so it was a pretty incredible system to watch her build out. And I do need to follow back up with her because it's been a couple of years and I'm sure it is incredible.
That's such an extraordinary story, Diana. And you know what strikes me most about it is that it sounds like this is a physician who didn't go into it saying, I'm going to develop some fancy value based care or these crazy analytics or metrics. She was solving a very real and practical problem in her community of teenage pregnancy and or the follow on teenage pregnancy and or multi-generational pregnancy. So that's amazing. What were the outcomes like?
It was incredible in all of our other sites. So we were on different reservations. We were in different sites of all of our sites. We had a couple of really big rock stars in kind of the Prescott area. There's a pediatrician up there that is phenomenal in her practice. And then we have one in Maricopa phenomenal and still amazing resources. But when you get more rural, because they're still a little bit, within 30 minutes of all of the urban areas, but you get more rural for us and for what we were trying to build. Now, we were a little bit fortunate for her in the fact that she had already envisioned, her and her husband had already envisioned a value-based program and had already envisioned what if it wasn't about the dollar and the hour and it was about the outcomes. So they came to this with that, where our other sites wanted to access the federal money. So they were hoping that we could give them solutions. And I think that the two largest hiccups that we ran into in all the rural areas was connectivity to internet, because that even makes access to specialty providers hard. I mean, there was just a lot of issues there. And then transportation. That generally speaking, the reason why folks weren't following up with medical care was because they didn't have means of getting there. And, if you have a child on the spectrum here in Arizona, and that is the concern, there are transportation services, but they're limited. They're limited just like many others, and workforce and funding and safety. So many of them will say like, "We'll transport your child, but not a nonverbal child," or "We'll transport your child, but you need to have a behavior tech with you." And so there's all these like logistics around transportation. But in their system, they didn't have that because they chose to do the cohorts. So without outwardly saying like, "Hey, you're going to give each other rides," it was organically building community relationships. And so when we first started with them, they were in a small facility. I say small, it was rather large until they were able to secure the funding to then buy out an old school building. And they redid the entire school building. They did a theater room. That's when they did the coffee shop. They redid the entire outside playground. So again, trying to get everybody to come and see. And I gone to lunch with her a couple of times, the doctor, and it was incredible driving through a neighborhood where everybody knew her and waved and the kids all hugged her. And so she brought so much of a human element that, based on how much they've grown into, gosh, they're in 3 other towns now. So Douglas is one of them, but they're also in Bisbee and in, one other, they might be even in 4 now. Based on their growth, I'm going to venture to say that the outcomes are quite well, as far as the producing the outcomes in order for the federal government to continue to, increase what they're paying out to them. As far as the study on the teenage pregnancy, I think that's gonna, be a multi-year study. She was just getting it started. I think their average, I don't remember the numbers, but they were kinda crazy. By the time individuals were 15, 16 in high school, I think they were at about 70, 80% of their females were pregnant or had been pregnant. It was a very, very, very large number. And so, yeah, I need to circle back with her and see kind of what her current data is. But given the nature of the study, those individuals, the impact probably isn't seen quite yet. But I would imagine that over time. But that brings me to a great point. Value based isn't about outcomes always today. Health plans are looking at long term ROI and per capita changes. And so, even if she didn't move the needle in the last 6 years, if she's got a system that still leads her to a hypothesis that's going to move that needle, that's still salvageable with the health plans and her federal contracts, because they're not looking at the solution for, okay, how do we make sure that 16-year-old Jill gets her 4-month in for shots? They're looking at, how do we make sure that that 4-month-old at 16 doesn't have these comorbid medical or mental health issues or these other things as a result to this today. So it is more of a longitudinal long-term study.
Well, I think it's amazing the extent to which she got embedded in the community, and I think that's a great learning for our field of how important it is not just to coordinate care with other providers, but to be embedded in the community and have a farther reaching change. And I wonder, Diana, are there metrics you think for ABA providers that You can start measuring right now if you're not already thinking about clinical quality and ways of communicating back to payers your clinical quality.
Yeah, I think we have to one and ICHOM does a really good job with looking at social determinants of health. Again, I think the biggest hurdle that we have as ABA providers is that in school we're always taught, single subject and peer reviewed articles and this is it, this is the thing. And so because that's unique to our field and others in the healthcare industry do their research different, it's still evidence-based, they're still producing incredible outcomes. They do it different. We kind of are quite dismissive of other healthcare literature, and I think that if we were to start to tie into the other healthcare literature, starting with what is literature telling us now is impacting health outcomes in adults 20 years from now. Because what I see in the field is we're looking at, okay, how do I get, maybe a 4-year-old with autism integrated with their peers in the mainstream classroom in first grade? Health insurance doesn't care about that. I mean that very nicely, but they don't. There's a component of that that matters because what we know in social determinants of health is that the less of access to an appropriate education, the lower amount of or quality of opportunities to engage in the education system are indeed long-term healthcare costs metrics. And so it's almost like we just stop there and we're missing that bigger piece of what makes the academic performance important to health plans. And it's not that they're getting along with their peers or they're mainstreamed or they can read or write. It's that we have data that says that by having those specific skills, you are actually going to drastically change your overall access to healthcare quality, the frequency, and then the prevention of other healthcare disease. And so, usually, when I'm talking about medical necessity or value based care, I know that the literature says disease, and I know that that's not necessarily like what I would go out and say, "Hey, I'm treating this disease." I don't mean it like that, but I want to tie it back to how important it is that as behavior analysts, we are able to crosswalk what some of those things mean. And when you look at the health plan, a health plan or the insurance companies, the industry in general, their job is to incentivize reduced cost to the government. And yes, there's a lot of other pieces to it. Like we want people to be well, we want people to be healthy, and we want them to strive and do good and contribute to society. And yes, there's all of those pieces. But every single one of those kind of go back to that one metric of like it still has to be at a reduced cost to the government. And so I think that for us, what we have to start measuring is that bigger picture back to the social determinants of what is the other healthcare literature saying about an individual that can't access a gen ed classroom. It doesn't mean that they need to be in a gen ed classroom. It just means that we need to go in and we need to say, okay, what does the literature say when individuals are limited in this access? Oh, it says they're at a greater increased risk of heart disease. They're at a greater increased risk of obesity. Those are going to be the metrics that we have to start thinking about, talking about, running numbers on, and kind of looking at that. And I would say in behavior analysis, we have that added piece of so often by the time our individuals are 8, 9, 10. I used to say 14, 15, 16, but it's down 7, 8, 9, 10. They're being treated with psychotropic medications. And so again, we're talking what are the side effects? What are the increased costs to a health plan? And how can behavior analysis reduce the need for psychotropic medications? And don't get me wrong, it doesn't eliminate it for everybody. And there's research out there that supports some co-treatment and stuff. But how do we reduce that? Not thinking about like, hey, we can solve this with behavior analysis and, maybe kids should or shouldn't be on medication, whatever, but thinking about, wow, this medication, if you are on it for the next 20 years, makes you susceptible to all of these high cost comorbid diagnoses and all of literature available to us. It's just in other healthcare realms. Um, the other one I'll touch on just real quick is family health. Um, especially in a value-based system, oftentimes they're looking for a holistic. In fact, in value-based systems and in medical necessity criteria, the family is a component of that because by not treating the individual holistically, sometimes what will inadvertently happen is that we create other high cost healthcare needs for the families. And so we have to cover that piece too. So definitely the metrics for family care. One area that I have been very, very interested in, we have a couple of other professionals out here in Arizona, is again that kind of preventative care for siblings. Because again, these are high stress. It shows that many siblings of individuals with developmental disabilities may also have coexisting or comorbid or develop a mental health concern at a later date. And so, how do we start to take that in and start to incorporate that into our treatment and then turn that around to the health plans and say, like, hey, we hear you. Our colleagues in these other fields are saying, guys, what's going on? We keep getting this influx of these other disorders. And we hear that. And so now how do we make that a part of our plan from a perspective of preventative health that then the health plan can say like, okay, yes, because what you're doing isn't just helping little Jose make it into first grade. You're now helping Jose's family reduce those costs. And again, health plans do everything off of per capita, which is very strange for us because we're very individualized. They can't be because they're serving hundreds of thousands of people. And so they have to look at it from a different lens.
Diana, this should be such a duh for our field. This idea that no child exists in a vacuum, right? And think about something that has nothing at all to do with behavior analysis, but like a parent losing a job and having to go from commercial insurance to Medicaid. And sure, there's all the logistics and coordination involved in the financial end, but even more importantly, like the blow to someone's psyche and mindset of getting laid off, of having to switch and potentially making a decision not to continue to access ABA, right? Like if a child is a part of their environment. And if we neglect thinking about family support systems and siblings, we're missing the boat as a field on what's best for kiddos and families. Can you, Diana, just clarify for listeners what you mean when you say social determinants of health?
Yeah, absolutely. So, our social determinants of health are the concept that the environment in which we have access to necessities, and that's going to include healthcare, our social environment. It's not as simple as like, do you have access to peers? No, no, it's the quality of the relationship with the peer. And so, again, healthcare literature for many, many years has been looking into the effects of not just, again, do you have access to a peer, but also what is the quality of that peer access and what does that mean for long-term supports? They look at education and just all of the things that we may not think about when we're thinking of, I have a toothache or I have a broken leg. We're not thinking about all of these other things. And I'll be quite honest, where most people understand social determinants of health and where the literature lies and I think needs to be better highlighted is again these marginalized communities because the problem that I think that we have and that I think, insurers have is we're trying to create systems that are one size fits all because it reduces costs to us. But as we do that, we continue to push aside these marginalized communities. And one of the things that the social determinants of health can do, if you're looking at those outcomes, you can start to look at, again, the impact that access to food and not just any food. Again, we're talking social determinants of health are about quality. It's not about like quantity and accept. You can have access to ramen. That's not what they're talking about. Do you have access to fresh vegetables? Do you have access, to these things? And in the primary care practices over the last 2 years, and I don't know if you've seen it with your kids, my kids have gone to a pediatrician that I actually worked with in the training cohort. And every single appointment we get asked, do you have transportation to your appointment? Transportation is one of those social determinants of health. If you do not have adequate transportation, your healthcare metrics are going to be significantly worse than somebody who does. And so it's looking at kind of those pieces. Again, And we run into this in our DCS system and different things where people are like, well, but you have food. Well, yes, but if all you have access to is ramen and mac and cheese cups, that doesn't solve the issue. You need access to fruits and vegetables. And my doctor asks every single appointment for my kids, do you have fresh vegetables? Do you need help accessing clean water? Like things that, I mean, for many of us, we may take for granted, but those sorts of things in healthcare matter in preventative health at such an early stage. And again, we can't look at it of like, oh, well, this family has access to these things. Well, no, we're working with individuals who their ability by the nature of some of, some of the strengths that they have and and some of the areas that they need, they have opportunities for growth. When you're looking at those pieces, it isn't the same quality. So, yes, mom and dad may be able to transport, but if they can't safely transport him when he's 21 because he's unable to safely stay in a seatbelt, well, that's gonna be a problem. And again, I don't know that we're thinking that far ahead. I don't know that we're looking at all of those pieces that make access to healthcare, and I think that's very evident in our group homes. We have failed to generalize across time our own programming. And when you look in group homes, oftentimes these individuals had families that had access to all of the similar social determinants of health that would yield to positive outcomes. However, that individual may not have, or that individual's access to it may have been restricted because of the nature of their needs. So social determinants of health is looking at kind of those things that start at a very young age, but they impact long-term health outcomes.
And I want to put a really fine point on this, Diana, because the concept of social determinants of health is not a new one. I mean, it goes back, I think, 25 some years. And was it 99 or 2000, sometime around then? I think there are a couple authors, Wilkinson, maybe, and Marmot, who published a book called Social Determinants of Health that said and presented evidence, among many other things, that differences in health between populations can be due to different characteristics in society, not just differences in healthcare. And that was a really powerful concept, right? In our field, you don't hear people talking about SDOH, right?
Mhm.
But who's talking about it? I mean, families are living it every day, clearly. Funders, insurance companies are talking about it because they understand this and they get this. Pediatricians talk about it. Other parts of the healthcare system talk about it. So I think it's really important that we bring this into our lexicon and think about how we contribute, even if what we're doing can be interpreted narrowly as ABA, it fits into this context of an environment of broader social determinants of health. That's critical.
Being value based, and that's obviously one side. Right now, most of our contracts are not value based; they're fee for service schedules. And one of the things that I will say to that is the appeals processes are not sensitive to the social determinants of health either, and that's something that a couple of colleagues and I are wanting to eventually put together a panel. And I actually was talking to one of the attorneys that frequently attends the Autism Law Summit, because when we're doing appeals, we again go right back into ABA and what the research for ABA says and yada, yada, yada. Well, what if I'm doing an appeal on an individual who historically had a reduced access to, for whatever reason, whether it's they individually did or I have the healthcare literature that says this particular population, for a myriad of reasons, is going to have a later diagnosis or have later access to care or later social validity and family, treatment acceptability. That's all data, even though it's not in our literature, that's all data that I could be using in appeals specific to that individual that has nothing to do with me and my treatment plan. It has to do with, at this point, all of the same reasons that you're denying these services, all of these same reasons in other healthcare literature are already addressed. So let me bring that literature in and show you. And I think the more that we can have conversations with health plans where health plans understand that perspective. And it's hard because a part of me is like, I want health plans to understand behavior analysis. I don't think that it's not that they understand or aren't striving to understand. It's that they're trying to figure out how we serve that bigger mission of reduced per capita healthcare cost. How do we prevent illness and disease? And we don't think about our services that way. We don't think about our services as I'm providing ABA. And I say this to families all the time. I actually just did an intake for a 9-year old who is not toilet trained. That is a preventative health issue. Me toilet training him is no longer a, hey, I want to make sure that you are good to be able to get into this preschool program. No, I'm needing to run a toileting program because this is a healthcare issue if it's not addressed long term. And that's what the health plans don't hear enough from us on. They just see, like, hey, here's this plan and we're going to work on these goals. And then in peer reviews, when they ask why, they get a lot of like, well, I ran the VV map or I ran the ABLES and this is what they said, or the parent said this is the concern. And I think we have to shift that and say, well, here's why, because we've got an increased risk of being denied social access, which is, again, let me show you the literature that shows that that long term is going to create higher cost health for you. Uh, Urinary tract infections, frequent urinary tract infections, and now urinary tract infections of maybe somebody who's nonverbal and unable to tell you. So they don't just manifest as just an infection, they actually manifest as a behavioral emergency. And I can tell you in the group homes I work in, a medical condition like that could take a year or two before they can actually resolve it because it's masked by all of these behavior issues. And these behavior issues are getting different strategies tossed at them and medications tossed at them. At the end of the day, it's like, who thought to just do a basic medical review? Who ran the blood work? Who looked at, hey, this individual may not be independently toilet trained, or who did all of that? And oftentimes in behavior analysis, we don't. Our new ethics code does call for us to consider the medical piece, but for years, that wasn't always the first go-to. It was, what are the 4 functions of behavior, and let's run an FA, and kind of miss that piece. But that piece is so important because that's where our communication to the health plan comes in. I'm going to justify my treatment because I know that if this is not remediated, here are all the other high cost procedures you're going to be faced again. Feeding therapy, same thing. A 4-year-old who only eats Oreos is subject to, based on other literature, heart disease, obesity, all these other things. So I'm not treating this food selectivity because mom and dad targeted it or it showed up on one of my questionnaires. I'm treating it because it's medically necessary to prevent other high cost health. And I just don't think that's the way that we're advertising and communicating about our services.
Oh, and by the way, adults who are not toilet trained have a much higher incidence of sexual abuse in group homes and other settings. I mean, Dr. Mike Wright, one of my co-founders at Ascend, helped me understand the importance, just as you're describing. This is super enlightening. I want to turn, Diana. You were one of, I think it's only 2 behavior analysts who were governor appointed to the Arizona Board of Psychologists Examiners, and you're on the behavior analyst committee, which is extraordinary. Tell me, what are the most important things you've learned in your tenure?
You know, it's funny. I swear I'd never get into politics, and healthcare is politics. And I guess I never realized that when I wanted to be in healthcare. And so for anybody who's out there thinking I'm just going to go out and help people, but stay out of the politics, um, not going to happen. Healthcare is politics. So Dr. Davy and I are the first behavior analysts to sit on the psychology board here in Arizona. And we were also a part of the original writing of the bill back in 2009. It went into effect in 2010. We didn't get behavior analysis representation on that board until 2017. And so between 2010 and 2017, Dr. Davy, myself, Kyle Leininger, several of us would just show up at meetings because we're like, hey, we want to be a part of this and we want to grow and we want to learn. And then we finally, with the help of Kyle and his team, we were finally able to pull the trigger and get some laws passed that allowed for us to be on there. And I've learned quite a bit between that and my doctorate as far as, I think as a field, everybody means well, but I think we misinterpret a lot of intentions. For example, the RBT credential, this is an easy one, right? The RBT credential, a lot of people are like, well, the BACB says you need 40 hours of training and then you're good to go. And you just need this supervision 5% of your hours every month. Yes, that's what the BACB says, but it's one part. Our ethics code also says that they must be meeting fidelity. You can only delegate things to them that you know that they have competently met. And so I think what has happened is because everybody's kind of just honed into like, okay, I'm going to make you an RBT and I'm going to set you up with that insurance company. What has happened is the assumption that the BACB is the regulatory body in all of that has created a lot of confusion for behavior analysts. And in that, you've got your Department of Insurance and your federal laws guiding insurance, and you've got your regulatory processes like licensure, and they actually trump the BACB. So when you just come and say, well, the BACB says we only need 5%. And I call it a misinterpretation because I don't think that what we're asking for, what the health plans are asking for or expecting is different than what the BACB is saying. Or look at now it's the CASP healthcare guidelines, right? It's not that they're different. It's that we're honing in on one piece to just dot I's and cross T's, and we're not actually looking at the purpose and the reason and what that means to the end user, what that outcome is. And I think that since I've been in the regulatory role, I see that a lot. Is that there's a lot of colleagues, a lot of behavior analysts that just come out and are like, but the BACB said. And it's like, yeah, there's one place that they say that, but it's also in addition to all these other standards. And and I'm glad that the BACB transitioned the health plan standards to CAS because I think that also muddied it a little bit, where then people were like, well, the BACB said, and it's like, no, no, the BACB isn't just an autism provider and all these things. So now CAS can really take ownership over this is standards of care for this population. And as we continue to grow as a field, we'll have standards of care that other professional organizations will be able to set forth and communicate that with the health plans. I think in regulation, that's been my biggest thing is that we are missing the mark in really focusing on the outcomes. And instead, we're so busy trying to just make sure we're dotting I's, crossing T's, and that's it. And then I think the other thing that I've learned, part of it in regulation, I think part of it in other work that I do, is that not only is value based care an important initiative for us to go to, but I think that we have to start to think about that in how we pay our employees. And so often we have so many bonus structures and stuff that are set straight to just hours that are either not attainable because the tasks that are required, like let's say of a BCBA to do for case management, isn't always billable. So when we have these billable quotas, people are overworking without it actually having meaning. Has meaning to many of the organizations because their direct care hours are the ones that they're looking at, but it doesn't have meaning to that tech meeting the competencies to be able to meet the outcomes for the child. And I think that's where we start to kind of lose that. And again, in the regulatory side, that's a lot of what I see. We have a lot of conversations around budget and legislation and legislative sessions and how these things all go together. And I think it gives me a little bit of a different perspective than most when it comes to what health plans are experiencing, because many of them, especially the access plans, they have to stay within that cycle and they have to play those politics and they have to do all of that. And in Arizona, we have incredible stakeholders at all of our health plans that are high level and they believe in us and they believe in what we do and they support our services, but they still are working within a system. And we have to understand that system. And that system is within more of a larger legislative piece. So I think, yeah, I think healthcare is politics. And that is probably the biggest thing that I've learned. And I think as a field, we need to do a much better job in outcome measures and making sure that we are creating systems that are ethical so that we can meet that. And I think value based care is, I think, the avenue that's needed. I do think the fee for service creates a burden. It's almost a hindrance that kind of just bottles everybody into this area. And I think value based care could open that up and then regulation come in and make sure that people are actually meeting those outcomes and support and training our colleagues into not just being stuck in that bottleneck.
Hey, you heard it here first, listeners. Healthcare is politics as much as we don't want it to be. It's so true. You refer to ACCESS, the acronym for the Arizona Healthcare Cost Containment System, which is Arizona's Medicaid system. And I can attest to the level of just the stakeholder advisory groups of getting input from the community and how much work ACCESS has done. And it's, dozen or so managed Medicaid plans to make sure that we're moving in the right direction. Well, Diana, what's one thing every ABA business owner should start doing and one thing they should stop doing?
That's a tough one. I think we need to start looking at outcomes and system outcomes, not individual child making progress, but larger outcomes, and not just the child making progress, but also the technicians and RBTs. I think that again we get kind of stuck in are you going through these motions and not are they making progress? I think everybody's really good with the making progress piece. I think it's those bigger long-term outcomes where we start thinking about how we're going to generalize these skills across time for these individuals. I really think that that should be a thing. And honestly, I think that although value-based contracts aren't they're there and not necessarily for ABA where we want them to be. They exist in other realms, and we know that to be true in hospital and rural community centers. We know value-based contracting exists. Um, Even without that existing, though, I do think that we can set up infrastructures to be more intentional about applying behavior analysis to our systems. And so, again, how we pay our employees, you look at various balanced scorecards and things like that, as opposed to incentivizing the hour, because we know that the health plans are incentivizing the hour and it's causing it to be very difficult for us to operate. And so apply that then to your employees. And when we incentivize the hours, and you're like, hey, you got to bill 30 hours a week or what have you. And that's the only metric that we're kind of looking at. I think that it inadvertently creates an issue with those outcomes because the BCBAs are just trying to meet their metrics or have access to a bonus because they need the money or what have you. And it's at the expense of not having the precision that our field actually brings to the table. And so for me, it would be even without the value-based contracts, starting to look at getting the field used to conversations like, "Here's your base pay, and here's your potential scorecard," and getting people to start looking at some of that discretionary effort and looking at ways that we can incentivize that aren't just that billable hour, because I think that's gonna make it very difficult to articulate the value-based care, but then also meet those metrics when it is afforded to us. I think a lot of health plans are gonna come back and be like, "You guys don't really know what you're doing," but that's because we've done so much adding bonuses and pay raises, and if you bill 30 hours a week, you get X bonus. If you bill 35 hours a week, you get this bonus, and now all of a sudden we're gonna be like, "It's not what you bill, it's how we move kids through the system that matters." I think that's gonna be a little bit of a different shift for us, which is surprising because, scorecards and value-based systems, by the heart of it, are behavior analytic. But we've all just been taught under this fee for schedule, and we just do it. But if we can start to envision how we make our systems operate more behavior analytic, then I think that, that transition will go much better.
Ugh. So stop with the misaligned incentives. You make such a great point. These are all the balanced scorecards, which is just this series of measures, right? That would lead to a quote unquote successful team member, right? And so because of behavior analytic, it's stuff we should be leading into. Amen. I love it. Diana, where can people find you online?
The easiest place to find me is just on my website. It's going to be www.aspenbehavioral.com. I'm also a professor with Ball State University, so I'm up on their website. You can find me there as well. So Ball State University or aspenbehavioral.com, or my email is just diana at aspenbehavioral.com. Pretty easy.
Oh, I love it. And we didn't even get a chance to talk about Aspen and all the powerful work you're doing. You all do serve kiddos, and you really, the heart of what you do is serving as a training ground to produce the strongest behavior analysts who are most well equipped to go out and serve kiddos. It's just phenomenal work what you're doing, in all
Yeah.
walks of life, from politics to actual supervision to the teaching and everything else, Diana. So tell me, are you ready for the hot take questions?
Yeah.
Here we go. You're on your deathbed. What's the one thing you want to be remembered for?
Oh man. Um, just that I, created a pathway for others that maybe wouldn't have been able to do it themselves, whether it was families in distress or a marginalized community. Our neurodivergent community is speaking right now. And so there's a lot of work that we can be doing there. And at the end of the day, that's what I want. I want for someone to look back and say that, hey, yeah, she she really gave it her best. There's a lot of things I can't make it perfect, but I do, that's how I got started here when I realized that had a lot of privilege and still couldn't navigate the system for my son, and that was when I knew I needed to shift from the clinical realm and get into the advocacy realm and do that work.
Right on. By the way, I didn't mention this earlier, but if audience, if you meet someone who's a homegrown Arizona licensed behavior analyst, there's a reasonable chance that Dr. Diana Davis Wilson was one of the OG mentors of either them or maybe their supervisor or their supervisor's supervisor. It's a pretty neat thing, and how you paid it forward. What's your most important self care practice, Diana?
Oh, that's a tough one. I like to spend a lot of time with my family, and I think being able to give experiences to my kids, has been the most. We don't always have that opportunity. I know self care should be, more about me, but I feel most fulfilled when I'm able to do things with my kids. It's hard. One has autism and it definitely throws a wrench into things, another's preteen, and then I have a toddler. So it's very, very bizarre. And I know it sounds really cliche and really odd, but having these conversations are really, really grounding for me. They don't take work. I don't think of them as work. So I really do enjoy being a visionary and times that I can do that, whether it's in my car driving. I do a lot of that where I will just say, I'm just going to drive the long way this time. Just so that and that's what I do. I just process like all of these things. I also do a lot of self reflection and I teach this in my classes after this call, I'll spend the next hour like, oh, yeah, and then I'll listen to it and be like, "I should have used this terminology, or maybe I could have said this different." And I do a lot of self-reflection because I like to grow as a professional, and personally, and I find that that has to start within myself. And so I do a lot of self-reflecting and kind of visionary work.
I want to emphasize this, listeners, of someone with the experience and the gravitas and the knowledge of a Dr. Diana Davis Wilson is spending that amount of time on self reflection and continuing to get better. It's important for anyone, everyone to do this work. Spot on. What's your favorite song?
Ooh, my favorite song. Oh, that is a really tough one. I Man, I don't know that I have one. That's gonna sound really crazy. I'm really digging Morgan Wallen right now, which is bizarre, and in just that, like, I am like old school country, and I don't know, he just kind of brings that back. There's a song out there, most people aren't even gonna know it, by Chris Young called "Drinking Me Lonely, Drinking Me Lonely." Anyway, it came out when he was on Nashville Star. Again, I'm a country music nerd. When he won the championship, the rendition that he sang of that was just like it still gives me chills. So that's probably, kind of my go-to, like, hey, I want to listen to this song. But again, it's kind of out there. Not a lot of people know it, but that Nora Jones is another one. I normally listen to country, but you put on some Nora Jones and I know that's not a song, but I'm not really good at remembering songs. I could sing it to you, but nobody wants to hear me sing. But
Oh, illuminating. I'm going to have to listen to that Chris Young song. What's one thing you tell your 18-year-old self?
oh man, probably to live a little, to go and experience things. And I actually didn't realize this till my counselor actually said it to me that interesting because if you ask most people in this field, I am very much a risk taker. I like to push some of the limits when it comes to advocating for families or like I'm a little bit more of a risk taker. I'll bend a couple of rules if I know that I have the documentation to kind of support why it's necessary for this particular circumstance. So I'm a little bit of a risk taker, but in life in general, I'm actually risk averse. And so I spent most of my childhood and early adulthood just, you know, living everything by like, you're supposed to do this and it's supposed to look like this. So we talked before this call that I've never gone skiing or snowboarding. Well, because there's risks associated with it. I don't swim because there's risks associated with it. Believe it or not, I didn't fly in a plane until I had to start traveling for conferences because there's risks associated with it. I don't let my husband drive because there's risks. So I don't know why I think my driving is better. I don't know. But yeah, I'm very risk adverse. And I wish that I would have spent some time at 18 kind of just exploring different things because now everybody is like, "Hey, so I'm way past those days." And I'm like, "I don't even know what you're talking about." Like those weren't even a thing. So I think just living a little, maybe taking some time to explore the teenage world. Learning to swim, maybe, learning to snowboard, something.
Well, Diana, you could only wear one style of footwear. What would it be?
Oh, definitely flip-flops. 100%. All the time. Um, Thankfully, I live in Phoenix. I've been told it's not appropriate to wear them to conferences and stuff, so I'll throw on some boots. Sometimes, if I'm in Arizona, like, that's my home, right? Like, I can show up in jean. They all know that I'm gonna have my sunglasses on my head. If my hair's brushed, that's been a good day. Like, I can do that in Arizona, but, I think other people get a little bit thrown off of my jeans and T-shirt when I present at conferences.
You will never throw me off, Diana. And hey, thank you, friend, so much for taking time and sharing your wisdom. I appreciate you.
Yeah. Well, thank you, and I appreciate you having me.
Hey, kind listener. Thanks for tuning in. If you like this episode, can you do me a favor? Give me a rating on your favorite podcast channel. It helps more values aligned people like you find the pod. Till next time, peace.
What did the janitor say when he jumped out of the closet? Supplies.